So newly diagnosed AML has evolved quite significantly in the last several years. We've been able to better understand and characterize newly diagnosed AML, not only by the cytogenetic abnormalities, which we've known for decades and categorized as good risk or favorable risk, intermediate risk, and adverse risk, but now we're beginning to add the recurrent somatic mutations that we discover over time. So things like FLT3 or FLT3, IDH1, IDH2, RUNX1, ASXL1, TP53, DNMT3A, among others, to help us understand a little bit better, not only about the underlying prognosis, the indication for allogeneic stem cell transplant in first remission, but also mutations that predict for response to certain targeted therapies. Furthermore, as we're developing newer and newer technologies, some of these mutations are being used as markers of minimal residual disease that can be quantified and measured at the time of remission and then throughout their remission course until the time of relapse to predict for relapses in patients. The most validated one would be there is NPM1 as a single somatic point mutation. So the treatment of newly diagnosed patients who are younger and fit for intensive chemotherapy has certainly been modified because of understanding this biology and the availability of new drugs. What we at MD Anderson often propose is to characterize the leukemia upfront, do it quickly, do it efficiently on all patients, understand their biology, and then assign appropriate therapies on clinical trials based on their mutations. So newly diagnosed FLT3 mutated patients, we often give intensive chemotherapy with a FLT3 inhibitor. In younger patients, based on the data showing that high-dose cytarabine may be beneficial in patients under the age of 46, and as well as the use of Cladribine. Our frontline approach is CLIA or Cladribine plus Idarubicin plus high-dose cytarabine combined with a FLT3 inhibitor, and our approach is to use gilteritinib on a clinical trial in newly diagnosed FLT3 mutated patients. In patients who are FLT3 wild type, we consider the use of CLIA, the same regimen, in combination with Venetoclax. So as you know, Venetoclax has been approved recently in older and unfit patients with low intensity therapy. We are now studying the combination of Venetoclax just for 7 days, combined with intensive chemotherapy to see if we can achieve higher response rates, deeper response rates, which can eventually convert to longer remissions and potentially cure in a patient population. We just published our experience recently in Lancet Hematology, demonstrating a very high remission rate of over 90% with a high rate of MRD negativity. Long-term follow-up will tell us about the relapse-free survival and overall survival compared to historical controls. And so that's our approach on clinical trial for newly diagnosed patients who are FLT3 wild type with intensive chemotherapy. There are a subset of even newly diagnosed patients who are younger and fit, but who come with complex karyotype P53 mutations with a high VAF, often 40% or higher variant allelic frequency. In those patients, although they're young and fit, our data suggests that their outcomes are essentially unchanged, whether they receive intensive chemotherapy or lower intensity therapy. In fact, the remission rates are very similar when you look at intensive chemotherapy compared to low intensity therapy with or without Venetoclax-based approaches. And the mortality, the early morbidity and toxicity is certainly higher with the intensive chemotherapy. So our approach in these newly diagnosed patients with P53 mutated complex karyotype adverse AMLs has been to consider lower intensity therapy on clinical trials with novel agents to see if we can get them to remission in a decent shape and try to get them to allogeneic stem cell transplant in first remission. In patients with newly diagnosed core binding factor AML who are young and fit, we used a combination of FLAG or fludarabine and cytarabine, high-dose cytarabine with GO, gemtuzumab ozogamicin, based on data suggesting that the use of gemtuzumab ozogamicin lends a significant survival benefit, probably the highest OS benefit in those patients with favorable karyotype AML. And certainly we've seen very wonderful outcomes in newly diagnosed core binding factor with this combination, with close monitoring using real-time quantitative PCR for monitoring of minimal residual disease, appropriate log reduction after 3 cycles, and then looking for any evidence of relapse. So those are the sort of the outline of how we treat newly diagnosed young and fit patients, characterize their leukemia, try to assign them on clinical trials that make sense based on the knowledge that we have, constantly learn and then adapt our focus and adapt our practices going forward.